Welcome back, everyone. Thank you for coming to the Women's Health Hub. We had a meeting about next year's plans, which we're very excited to share with you. We're not quite ready to share, but we're going to have some more education. And just kidding. We are actually trying to open a women's health clinic.
Thank you, everybody.
Yes. Thank you, everyone. It's you showing up, doing your homework.
Pre and
post test questionnaires, which is helping us get there. So we have space. We have other physicians that are interested in joining us. It's going to be a women's health clinic focused on menopause, but open to doing other things, IUDs, endometrial biopsies, consult stuff, because there's a few of us that have a special designate in women's health through family medicine, and we're all interested in contributing. So that's very exciting. So stay tuned. And this is not just for people who are attached to a primary care. This clinic is also geared towards unattached patients who don't have access to primary care, which is extra exciting. So before we get started, I would like to do a land acknowledgement. We would like to respectfully acknowledge that we are on the traditional territory of the Anishinaabe under the terms of the Robinson-Huron Treaty 61 of 1850 and the Williams Treaties of 1923. We are grateful to be here. We hope you are too. We commit to acknowledge, learn, educate, create opportunity, honor sacred places, and take actions towards real truth and reconciliation in support of our commitment to walking the path together in respect, peace, and harmony for future generations. So tonight we're talking about pelvic health, body image, and confidence through menopause. Before we get started, I want to have a special shout out thanks to Ashley. Where are you? Ashley came an hour early and taught a few of us a Learn to Lift session. Thank you for your time, for your expertise. It's awesome having you a part of this. We also have very special guests that I will introduce after the first part of our presentation. We have the pelvic floor gurus. The women that I tell every one of my patients about. Carolyn and Brittney Vandyken are here, and I'm very excited that they're here to join us and educate us. But first, has everyone scanned their code and done the pretest? Yes. Allison, are you doing it? Yeah. Yeah.
Yes.
Yeah. So I'm going to pass the mic over to Angie.
Thank you, Lindsay. Yes, this is very exciting. So for the first half, we're going to be talking a little bit about body image and our confidence through menopause, because I'd be remiss in talking about it. I don't know how many of us have walked by the mirror or stood in front of the mirror and been like, who in the hell is that staring back at me right now? Sometimes things shift and move around, and it impacts our body image and our self-esteem. So hopefully by the end of today, you'll have, maybe not the most, even if you come from a place of super negative about your own personal body image, you at least get to a place of a little more neutral. We don't have to be uber, super, yay, everything's positive. I'm going to love my body, because we might actually hate it, unfortunately. If we can get to more of a neutral place, that's what I'm kind of hoping to give you some tips and tricks through that today. And for many of us, I think menopause can be a turning point. It's a chance to shift from chasing our appearance to embracing authenticity. I've met a lot of women who are postmenopausal who say, I'm so free now. I am liberated from the confines of the social structures and social norms that have been placed on me since I was a child, as a woman, right? So, maybe right now if we're through our menopause transition, or maybe a little bit early, and we're struggling with body image stuff, on the other side of it, many women are just like, yes, freedom, finally. I don't give a shit what anybody thinks of me anymore, which can be quite liberating. But not all of us feel that way. Some of us, but not all of our experiences are positive. Our stigma and internalized criticism and fear of judgment are still all too common, and that's why we're here, to open the conversation, challenge the stigma, and reconnect with our bodies, and including our pelvic area, which I'm so excited about. So I might rush through this because I really want to hear them talk. That's why I actually, you guys know me, so I created a script, because if I don't, I will go off on like 38 different tangents. I was literally just diagnosed with ADHD, so I know, shocked everybody here. Complete shock. And no, I didn't take my medication today. I still wanted to be a little bit fun. Okay. Sorry, see, that's why I have a script. I would be remiss if I didn't talk about our body image across the lifespan. Adolescence, as we know, so many judgments and labels and everything placed on us that we placed on ourselves. When we were younger, it was like the teen magazines, and now it's just social media. And I really feel for the young girls because it's in their face all the time. We used to have to go buy a magazine or watch somebody on TV to compare ourselves, and now it's just constant in their face, and their mental health is really struggling. But, you know, hopefully we can get to them, all of us wiser individuals. So our body image story starts young. In adolescence, it's often shaped by peer pressure and media. In adulthood, we're told to bounce back. How many of us heard that after pregnancy, for those of us who had kids, right? You want to bounce back. You want your pre-baby weight, like your pre-baby body. You can do it, all these things, right? And it's like, that's not going to happen. Our bodies are incredible. They're meant to morph and change. And then menopause hits. When you might have bounced back, or maybe you didn't, it brings visible changes. Society says we're supposed to hide. If you show your skin, then oh my God. And if you you have to dress modestly. How many times you get Instagram ads that I do? They're just like, dress for your 40s, dress for your 50s. I'm like, dress however the fuck you want. Like, I don't care what you wear. Just feel good about it. Feel good about yourself. But yeah, so like I think I kind of put these up here because like how much, like, reflect on how these have impacted us over our lifetime. And I think it doesn't take much for us to reflect on that. And look at, a few of them there. And what's that?
The bunions.
The bunion. Oh my God. Oh, the bunions. Oh, I know. I actually started doing exercises for my toes to maybe get rid of my bunions.
Something else to do.
Right? Just keep piling it on. I do it in front of the TV, actually. While you're meditating and breathing deeply and doing your pelvic floor exercises and making the list of the million things you have to do tomorrow in your head while you're focusing on going to sleep and eating properly. Have we overwhelmed you yet with these? I'm going to circle back to that. But yeah, so like I was saying, this is my friend Susan. I'm sorry if anybody's name is Susan. It was just the name that popped up in my head. But she's a 52-year-old, recently entered menopause, always been confident in her appearance. But over the past few years, she's struggled, she's noticed changes in her body that she's struggled to accept, gained weight around her midsection, her skin's become drier, and she started to feel less visible in social situations. And she finds herself avoiding mirrors and feels increasingly anxious about her appearance and her periods. Hoping she doesn't get another one, because if she does, she's going to have to go to the doctor, because maybe she's got something wrong, because now she's postmenopausal. Something else to think about. But yeah, so it changes our bodies. Menopause changes our bodies. Menopause and aging. It's not just menopause. And our body image. And so I think it's really important that we're talking about this today with our pelvic health, because I don't think it's talked about enough. Just like our bones, people say, oh, your bones are getting brittle just because you're a woman and you're getting old. Oh, you have stress incontinence, it's just because you're a woman. It's totally normal, it's okay. Or you have pain with sex, whatever, you had a good run, hun. No. No. If I still want to be sexual, then I haven't had a good run. The run's not over yet. So yeah. Okay, next one. Our body image and stress. We talked a lot about stress in a previous session. And so, so imagine being chased by a lion. We all know what that's like, but our body knows what that's like. That's our body on stress. Now imagine the lion is our own voice. Self-criticism puts your body in constant fight or flight. We think it motivates us, some of us do, but it actually wears us down. And what if we replace that voice with one of a little bit more kindness? And I like to say, if a friend came to you saying this about themselves, what would you say to them? Say that to yourself, right? Would you say those kinds of things to your friends that you say to yourself? And again, not over the top positivity. I'm not, let's be realistic. I'm very much a realist. If I hate my body, I'm probably not going to get to a point where I love it, but I just want to be neutral about it. Yep, I have a body, and yet it gets me from A to B. And yes, I'm feeling okay in it today. My knee hurts, but okay, we're going to move on. And being able to get to that place of neutrality for those of us who may have really low self-esteem and body image is an important place to get to. You don't have to be super over the top positive about it. So how often do we criticize ourselves? Some of us is it almost every day, especially when I feel like I'm not doing enough. It's not just how we look, but what we do. I don't know how many times I've talked to you guys about ruminating on, how much of a bad mother I was, even though I think I was a good enough mom. And I think that's a really important thing. Oh, hello! Sorry you're late. Come and join us. Come sit in the front.
I just want to say that I might be postmenopausal.
That's okay.
I totally forgot.
We love you and we accept you just as you are. As you are. I couldn't see with my glasses on at first. Oh, glasses on, glasses off, glasses on, glasses off. So, the kind of things we're saying to ourselves. I tell myself I'm not good enough, that I'm failing at everything, whether it's at work or being a mom, taking care of myself. I should be doing more. Add that, extra thing to our list of things that we need to do to keep ourselves healthy and happy. Are we okay? Okay. I told you I was going to go a little bit faster. Yeah. Okay. Keep it rolling. Keep Angie on time. That is Lindsay's task. This is why I have a script. Okay, body image and intimacy, and I think this ties in really well with the chat that Brittney and Carolyn are going to talk about today. So when we're critical of our bodies, it's hard to be present in intimacy, and intimacy can be with ourselves, it can be with our partners, it can be in all kinds of different relationships. We withdraw, we can disconnect, or avoid it altogether. Maybe we don't want to, but that's the place where we've landed. But it's not about perfection, it's about presence. What if instead of focusing on what's wrong, you tuned into what feels good? The shift from judgment to curiosity can transform how we connect with ourselves and others. And I think if we have a more comfortable sensation in the pelvic area, that might help as well, of course.
How big is this pelvic area?
Metaphorically? Are we talking metaphorically? Because really, it's like, it binds us all. It binds us all. We are connected.
We are the pelvic.
I know. We are. We are. Oh my gosh, I have so many things to say. Okay, stay on track. Stay on track. Okay. And of course, as we've talked about, society's view of aging women, your body is not wrong, society is. Always keep that in mind. I like that one sign. Warning, reflections in this mirror may be distorted by socially constructed ideas of beauty. And often the ideas of beauty come from pop culture, right? When you look at the 90s, I grew up with Melrose Place, and it was what they called the lollipop, I think, is what that body shape was. Very thin, very tiny, anorexic looking, to be honest, very, very, very slender, unhealthy. And then we shifted to the 5 years ago when everybody had the beautiful big booties, like J-Lo and the Kardashians, and then of course now everybody wants to be super skinny again, so now everybody's on Ozempic. If we trying to keep up with it all is just a nightmare. And so I think we need to just be super aware of our own internal chatter making sure that we're being kind to ourselves as well. So changing the narrative, we want to redefine beauty, focus on strength and wisdom, create and support positive media representations. I got off of Facebook and Instagram a couple of weeks ago now. Actually, I downloaded an app called ClearSpace, and it makes me do squats, push-ups, or steps to get minutes on social media. And it's been brilliant. My mental health has skyrocketed. I'm more engaged with my kids. Anyway, I could talk all day about this thing, but it's awesome. ClearSpace. Yeah. I chose 10 squats for every minute. I didn't realize how many minutes I really wanted to be on Instagram until I was doing like 600 squats a day. No. But yeah, it's for those of us who have a hard time like myself, putting things down because I need to escape. It's a blocker because the screen time thing didn't work for me. I just avoided it. And it made me move, which was great. So community and solidarity, like we're doing here, super important. We need to get out. Identify and minimize body shaming triggers if we have them. Seek professional help if we need it. Of course, reframing thoughts from negative to neutral or even just slightly more positive. Every day is a new day. You know, we don't have to start all over again each and every day. Set performance goals instead of body-based goals. That was going to bring me to this book. It's called Healthy Habits Suck. How to Get Off the Couch and Live a Healthy Life Even If You Don't Want to. Her name's Dana Lee Bagley. She's a researcher and psychologist. I believe she's Canadian. And she breaks this down so simply to just be able to just keep it simple. And she goes into the psychology of why we don't want to do healthy things. It's evolution. It's not our fault. We're not lazy. It's evolution. Lift heavy shit, as Ashley was here teaching us to do that. Of course, that's always important, or lift what we can. Start where you are and do what you can. And practicing judgment-free body talk, of course. So that's my little blurb on body image, because it changes and it happens. And now, Lindsay.
I'm
so excited.
I know. So how many people know about Carolyn and Brittney? Raise your hand. Look. So it will come as no surprise that they're incredible educators, teachers, practitioners. I'm going to actually do an official blurb, but like I said, I literally, every female and a lot of male patients of mine will often hear me recommending pelvic floor physiotherapy for many different ailments and body changes. So Carolyn Vandyken is a registered physiotherapist, pelvic health educator, researcher, author, and co-owner of PhysioWorks Muskoka. 34 years of clinical practice. She's contributed chapters to 3 international textbooks on pelvic pain and overactive pelvic floor. She's co-authored a patient-centered book called Why Pelvic Pain Hurts, and has co-authored 5 research papers on pelvic pain, low back pain, and incontinence in peer-reviewed journals. Carolyn speaks extensively at international conferences on the topic of pelvic health and biopsychosocial framework. I have to tell you, about maybe 10 years ago now, when did you arrive in Huntsville? Carolyn got in touch with the group of doctors that I worked with when I was brand new and said, I'd like to come and speak to all the doctors about pelvic floor physiotherapy. And honestly, we're like, ha ha ha, woo, this is woo, what the heck is going on? I'm not joking. As a collective. And she came and she just knew how to get us. She talked all about the evidence behind pelvic floor health, the extensive training and knowledge that she had. She blew all of us away. And then since then, I've been hearing patients come back after seeing Carolyn or Brittney with actual being transformed in many positive ways. Brittney Vandyken is a registered physiotherapist and also co-owner of PhysioWorks Muskoka. She graduated with an honors Bachelor of Science degree from Brock University while playing as an academic All-Canadian on Brock's varsity basketball team. Pretty impressive. Following this, she obtained her Master's in Science in Physiotherapy from McMaster. She's received additional postgraduate training in soft tissue work, pelvic floor rehab, chronic pain, breast health, and oncology rehabilitation. Brittney has a passion for clinical research on lumbopelvic pain and pelvic floor dysfunction, and she's been published in the literature as well. So I am so excited and honored to welcome Carolyn and Brittney.
No, just tell us Carolyn. Thank you so much for having us here today, Lindsay and Angie. It's an honor to be here. I'm really excited, and I like to introduce myself as the daughter, because when we first started, everyone knew I was the daughter. 10 years later, they now often assume we're sisters. Fabulous for Carolyn. Maybe a little less fabulous for me. So there we go. I'm aging gracefully. I'm not going to repeat the land acknowledgement. Thank you, Lindsay, for doing such a wonderful job. We like to start a lot of our talks with this quote: if we do not change our direction, then we will likely end up where we are headed. I'm really thrilled. This is the first picture I've been able to use of this vulva. So we were just we had the opportunity to take a really last-minute trip to Madeira a couple weeks ago with my parents and my husband. And we were sitting there on the beach enjoying a beverage. I looked to the left, and isn't there a vulva? I'm thrilled. So I go running over, and I take the best pictures, and my husband and my dad are like, what is going on? Bless their souls.
She put her fingers.
And then I have a picture of one with my face, and Carolyn said I could not include it in this picture. Still the mom. But what I really like about this vulva, if you look closely, is that it is asymmetrical. It is different colors. And it doesn't look like any other vulva I've seen. Because every vulva I have seen has not looked like any other vulva we've seen.
Dinner conversation at your house.
We like to say my dad grew up with it, my mom starting, but my poor husband married into it. Anyways, bless his soul, he's great. How many of you think this talk is just going to be about Kegels? Not a time. Yeah.
How many have been in your clinic?
How many people do Kegels regularly? Amazing. How many people feel confident that you're doing your Kegels correctly? Yeah. Great. How many people know how to relax your pelvic floor? Also great. And how many people think that strengthening is more important than the relaxation of your pelvic floor muscles? Tricky question.
I used to until I met you guys.
So we're going to talk about all of these things today because there's a bit of myth busting that we like to do. And how many people find Kegels boring? I do as well. Okay, so in this talk, we're going to look at answering the following questions. Why should I care about my pelvic floor muscles? What are the things that will challenge me in this next phase of life if I don't care for my pelvic floor muscles? How should I care for my pelvic floor muscles? Spoiler, it's not about Kegels. How can I not feel overwhelmed as I move into this next phase of life? And I think Angie did a great job of thinking about what's our next best step, because there's lots of information, and so where do we start to think about this? So step one, why should I care about my pelvic floor muscles? So incontinence is a very common but not normal problem. It's very interesting. So if we look at the number of incontinent people in the world, it would create the 4th largest country in the world. That is a lot of human beings. The stats say in Canada that it's 1 in 3 women and 1 in 6 men. So usually in a talk like this, I say, look to your left, look to your right. At least one of you is going to be struggling with incontinence at some point. And it's interesting. We've been told, kind of like Lindsay and Angie were saying, that this is a fact of life. You've had a baby, pad up, move on. We're menopausal, pad up, move on. But we now know that there's really good evidence to improve that 90% of people can get their incontinence better with exercise and lifestyle changes. So it's common, but it's treatable. Why does it happen? So this is the pelvic floor. I forgot Petunia. Petunia's our pelvis. It was my responsibility to bring it from work. I did not. So I don't have the pelvis, so we're going to have to rely on the picture of the pelvic floor. But the pelvic floor is a group of muscles that spans from the front pubic bone to the back tailbone and between your two sits bones. As women, we are at more risk for pelvic floor dysfunction than men, so twice as common as you can see, because we have an additional opening, the vaginal cavity, in our pelvic floors. As well, we have hormonal changes, and many of us will have a pregnancy or a delivery, whether it's cesarean or vaginal. And the hormonal piece in perimenopause is really important as well. We see with pelvic floor issues often two main time points in a person's life, one postpartum and then two perimenopausal. And because of often that hormonal change. So we know from the research that incontinence worsens when we have a decrease in estrogen, and there's a pelvic floor muscle change that happens perimenopausally with this.
Brittney, can you just go into a little bit more detail of what you actually classify as incontinence?
Yes. And we'll chat a little bit about that, but there's a couple different kinds, and we'll talk about different types of pelvic floor dysfunction, because when we think about the pelvic floor, the most common thing we think of is incontinence, but there's quite a few things that we'll chat about as well. But there's technically five, but we think about three main types of incontinence. So there's stress incontinence, which is your cough, laugh, sneeze, run, jump. You're doing something that increases your pressure and you leak a little bit. Then there's urge incontinence, which I like to call the 0 to hero bladder, where 1 minute you're fine and the next minute you have to pee and you're rushing to the bathroom and you might not make it to the bathroom in time. So that's urgency and urgency incontinence. And we can have both, which is called mixed incontinence, which is typically the most common presentation. You can also have a subcategory passive incontinence, which is we don't know it's happening. You haven't done anything at all and it will leak out. And then you can have neurological incontinence, which typically happens if someone has a neurological condition, and then functional incontinence, which is if someone, for instance, has arthritis in their hands and they can't quite functionally get something like their buttons undone. So those are the main types, but typically you're going to see mixed incontinence, urgency incontinence, and stress incontinence with that. It's a great question. Thank you for that. And we'll talk about some of the other stuff down the road. Please interrupt me with questions. I'm happy to chat more. Any questions so far? Okay. So these muscles, I love them. I'm obviously biased, but most muscles in the body do one or two things. The pelvic floor muscles are the only set of muscles in the body that do 5 things. So the first thing they do is they provide stability for your hips, your spine, and your pelvis. So they can be involved in back pain, hip pain, pelvic pain, tailbone pain, SI joint pain. They provide sphincteric support, which is just a fancy word for closing off the urethra and the bowel. So they provide bowel and bladder continence or control. They support our pelvic organs. So in women, our bladder and urethra neck at the front, vaginal canal to cervix and uterus in the middle, and then bowel at the back. And so involved in pelvic organ prolapse, or when the walls soften and we start to see a little bit of bulging into the vaginal cavity. They have a huge impact on sexual function. Angie just talked a little bit about that. We're going to talk more about that shortly. But we should always, if we want to be having intercourse, be having pain-free, pleasurable sex. Last thing they do is act as a sump pump. So they help pump blood from the legs back up to the heart. So like a lot. They do a lot. And they are very hardworking and they're often missed. They've often been a bit of the missing piece for people. So that's question number 1. Why should I care about my pelvic floor? What does it do? Question 2, what are the things that may challenge me in this next phase of life if I don't start to think about my pelvic floor muscles? Back to the vulva again. So the World Health Organization in 2007 published a paper on the 4 geriatric giants of aging, or what are the 4 things that people are going to struggle with the most. 3 out of 4 of them are related to the pelvic floor. So instability and falls, there's good research and papers looking how pelvic floor is correlated to balance. Immobility, so a reduced ability to walk and move, again correlated to pelvic floor function. Incontinence, obviously directly related. And then the last one is impaired memory or cognition. So we need to think about moving more in all of these different categories. So, and again, in instability and falls, we want to think about general exercise, pelvic floor strength, pelvic floor relaxation, same with immobility and incontinence as well. And then in impaired memory and cognition, there is good evidence that those who are more active and maintain better fitness typically have less cognitive decline. So all circles back to some of those pieces. Who is more likely to have pelvic floor issues? We like to think about the acronym STAND as sort of 5 risk factor categories for that. So individuals who have a high level of stress, and we'll talk about that in a second. The pelvic floor is actually the very first set of muscles to respond when we feel stressed. So they've done some really good research where they hook women up to electric sensors, show them frightful or stressful imaging, and before we blink or move away, our pelvic floor responds. So we are hardwired to use these muscles to protect ourselves. Trauma. So if we've had a history of trauma of any kind, again, that wiring protection will manifest in the pelvic floor. Anyone with additional health conditions, so things like ulcerative colitis, Crohn's, endo, IBS, some of these other conditions can have a big impact on the pelvic floor. If we neglect our rest and recovery, so if we're not stretching enough, resting enough, or overtraining, we can develop issues in the pelvic floor, and those if we have decreased physical fitness. And it's not all about incontinence. We're talking a lot about incontinence today. There's the urge and stress incontinence like you asked, but we can also have pelvic organ prolapse, low back pain, hip pain, painful sex, painful periods, IBS, constipation, and bowel and bladder pain. So the pelvic floor does a lot for us, and when it's not working as well as we want it to be, we can start to see a variety of issues. And I often see in my clinic, someone will say, I came in for one thing, I'm leaving with 8. I feel like there's more going on, but it really comes down to the pelvic floor. And so because it does 5 things for us, and every function has different things, we can have urgency and frequency and painful sex and a painful period, and really looking at how that all correlates in the pelvic floor. And so why do we care? Why do we want to think about that? And why does it matter to us? Well, there are really big consequences for us. So there's been some excellent research that shows that incontinence alone is a barrier to women's participation in sports and activities. And as Lindsay said, I have a subspecialty or sub-practice in sport, and we actually see in sport that young girls or athletes who are leaking have decreased athletic performance, and they pull themselves out of sport sooner and have more increased mental health risks as well. So, and we also see that as women age, they will stop exercising if they're having incontinence. This then has huge impacts down the line. We're looking at quality of life, self-esteem, cardiovascular health. We know that exercise is one of the best things that we can do. And avoidance of that physical activity altogether is a huge risk factor for all of these different things. And so how should I care for my pelvic floor muscles? Are we switching now? I think we are. We are.
We debated, how do we do this? But I think this is where we're going to switch.
Perfect.
Yeah?
Okay.
Awesome. Thank you, Brittany, and thank you, Lindsay, for the invitation, and for Angie for this great program. Thanks, everybody, for coming. And so let's go on. And so one of the goals for me for tonight, because I'm postmenopausal, and I'm trying to sort it all out, and I'm trying to figure out how to fit it all in, and really kind of, if we want to change where we're headed, right, we have to think about, well, what has to change? And sometimes it can feel really overwhelming, right? It's like, oh, I could do this better, and I could do that better. And, I look back, my kids are all grown, I've got grandkids, and geez, I could have been a better parent, and am I a good grandparent, right? So all these things, we've all got a bunch of demands on us. When it comes to principles of good pelvic health and principles of just exercise or self-care, I like to use the acronym RAMS. You can see I teach a lot, so I like acronyms because that's how people remember things. So when we think about self-care, what we want to think about is relaxation, which doesn't fit well in our society so much, right? Activation, so walking, mobility, and then strength training. And not that I think strength training is less important, but I think almost as a society, we kind of put strength training and cardio up on a pedestal from an exercise perspective, and it is really important, but it is only a piece of the puzzle. And I think just putting that in perspective is really helpful for people. So it's not just about strengthening our pelvic floor. I feel like if I lift this a bit, I'm not leaning. That's probably better. Okay. So again, Brittney talked a little bit about kind of what we see from a social perspective and the consequences of not taking care of our pelvic floor. When we really look at the research tells us very clearly that it is not just about strength training. So we could argue that our athletes are amongst our fittest in our culture, and yet athletes who are incontinent have greater strength of their pelvic floor than continent athletes. So if it's all about strength, that really doesn't make a whole lot of sense, does it? Right? And we also know that there's a positive association between abdominal and pelvic floor muscle strength in athletes who are incontinent. So what does that really tell us? There's a lot of over co-contraction between our abdominal wall and our pelvic floor. And if we go back to self-esteem for a moment, raise your hand if, as a woman, you have learned to hold in your tummy a little bit. Right? Flat abs. Well, guess what? When you hold in your tummy, what else do you hold in? Your pelvic floor, right? And if your pelvic floor is like this, how can it do this when we need to cough, laugh, sneeze, jump, run? It can't. It's being held in inner range. So a lot of our young women who are leaking, even with stress incontinence, can we stop thinking that they have a weakness problem? There is not one reason in the world for a young teenage girl or an athlete to think they're weak. They do not need to strengthen their core. They do not need to do Kegels. They need to relax. They need to let go. They need to stretch. And they need to be comfortable with having a soft, relaxed abdominal wall, right? It's hard. It's hard, right? We've all been brought up. We see this in women with low back pain. So we published a study. So it's interesting when Lindsay read my bio. Clearly I have to update it. I've been practicing for 39 years now. I guess that was written 5 years ago. And we have published 15 studies now, which has been really exciting. So as a clinician, I have a passion for research because we really want to start asking questions around, well, what do we do and what works and what doesn't work, right? So one of the things we noticed about a decade ago was that most of my patients who had pelvic health concerns also had low back pain, right? Highly comorbid. So we actually asked this research question. We did a research study on women who came to a clinic, an orthopedic practice, not a pelvic health clinic, for low back pain. And of those women who came to an orthopedic clinic for low back pain, 95% of them reported at least one pelvic health complaint, right? Huge correlation. So then we were the first study actually to then do a blinded internal exam on those women to see, well, what's happening in their pelvic floor? Are they tight? Are they weak? Do they have pelvic organ prolapse? And by far, the majority of women were tight, much more so than weak, okay? So again, we have mounting evidence that it is not just about doing Kegels. We really have to think about kind of the whole picture. And we kind of know this in our kids, right? Where did we kind of forget that, you know, emotional distress for our children ends up in tummy aches and ends up in incontinence episodes, right? So if the pelvic floor is the first set of muscles to respond to distress in our bodies, it kind of makes sense that when we're distressed, we're going to have dysregulation or dysfunction in these muscles. Does that make sense? So if we want to simplify kind of our message here and really want to think about, well, what are the things, and I think this applies, I've listened, I unfortunately have not been here live yet, but I have listened online, and Allison did such a great job last month, just really simplifying this whole sort of nutrition concept. Ali did such a great job really simplifying this idea of stress and relaxation practice. And what we want to do today is just really simplify as well, what do we do about this? So if we really want to be more effective as we age in our bodies, let's look at the blue zones, right? Everybody know what the blue zones are? Does anybody not know what the blue zones are? Okay, well, then let's talk about the blue zones. The blue zones are, I think there's 5 or 6 areas in the world where they have the most or the highest number of centenarians. So people who reach 100. And in the blue zones, they've done a fair bit of study. There's a couple documentaries, there's a couple books written about the blue zones. And essentially, their lifestyle is actually very simple, right? They walk, they eat good food, they have strong social connections, they have a relaxation practice or a faith practice. They do some of these basic things really, really well. And when we do those things well, we live well and we live long. And that's really the idea, right? So what does that look like? So again, if you come to see Britt or I, we could tell you whether or not your pelvic floor has tension in it, or it's weak, or it's lacking coordination. But I like to think that we are all quite intuitive, right? And we have a sense ourselves around kind of what is happening in our body, right? So one of the things I want you to ask yourself is, if you're struggling with poor sleep, if you're struggling with persistent pain anywhere in your body, if you're struggling with an overactive bladder, can't make it to the toilet, I'm leaking on the way, or just a lot of urgency and frequency, painful sex, hormonal dysregulation, or you just have a desire to age well, and you have incontinence, probably the first thing you need to think about is relaxation, okay? Not Kegels. So what does that look like? Well, again, here's the study that Brittney was talking about by Vandervelde. So this is 21 years ago now, or almost 25 years ago now, actually. Geez, I hate when, yeah, it's like, wow.
It only feels like 5 years ago.
It was literally 5 years ago, yeah. But we know from good research that the pelvic floor muscles are the first muscles to respond when we're stressed. And it's about survival, isn't it? Sexual function, bladder function, bowel function, procreation. We could argue that everything that's important for survival happens in our pelvic floor. So if stress is part of your kind of milieu, if that's kind of how you're moving through the world and you've got incontinence, please first just get your system to regulate itself through some simple relaxation practices. And I'm going to quote Ali here, and just breathe, right? Don't make it too difficult. Set aside 10 minutes. So this is a picture of Dr. Herbert Benson from Harvard Medical School. He's recently passed away, but he spent his entire medical career looking at the connection between stress and health, and stress and disease. And he kind of boiled all of his research down to simply doing a 10-minute breathing practice where you focus your thoughts on one thing through that practice, and your mind will wander, because that's human nature. And when your mind wanders, you go, oh well, and bring your thoughts back to that one thought, whatever it is, a positive statement, I am beautiful, my vulva is beautiful, whatever, right? So you could do yoga with Ali, you could do a breathing practice. I'm a big fan of Qigong, meditation, Tai Chi, anything that actually calms your thinking brain will evoke the relaxation response. And if we do something for 10 minutes every day, great. If you do a couple of longer practices a week, great. But don't let a week go by, maybe a day go by, without thinking about calming our thinking brain and kind of managing that stress response. So that's relaxation. Activation. So what is activation? Activation is essentially walking. Can we start walking? We don't have to make this complicated. You don't need to join a gym, right? You can just go outside and walk. The nature in Huntsville is incredible, right? Go out and walk in nature. So if you have incontinence and you have any other chronic health concern, if you have persistent pain, if you're seeing a theme here, right? If you have an overactive bladder, if you have painful sex, if you have hormone dysregulation, so you're in perimenopause and things are going wild, if you have pelvic organ prolapse, or if you just want to age well, please start walking, right? And it doesn't have to be more complicated than that. It doesn't have to cost anything. There's a brilliant, do you love this? Oh, this YouTube? So I send this to my patients all the time. It sounds like Lindsay does as well. This is Dr. Mike Evans. He's a preventative medicine physician in Toronto who does these beautiful YouTube kind of white, black chalkboard kind of things. And he basically just takes a look through the literature and says, Listen, if Lindsay's hands were tied as a physician and all she could do was prescribe one thing moving forward for every health condition that you could present to her with, that one thing would be walking for 30 minutes, 5 days a week. That's it. That's it. Doesn't have to be more complicated than that, right? And so, again, that is a really good place to start. And I will often start with my patients with those simple strategies. The M stands for mobility. So, getting a theme here, if I have incontinence and I have persistent pelvic pain, low back pain, hip pain, overactive bladder, they're a little bit different. Painful sex, hormone dysregulation, pelvic organ prolapse, or just a desire to age well. I want to be a centenarian. I don't want to move to the blue zones, but I want to have the best quality of life for 100 years. And then, Brittney, I'm going to die at 100 years and a day and be done. Just warning you, sorry. You got a long time to live beside me yet. So how do we mobilize our pelvic floors, right? We need to think about some great yoga postures like pigeon, for example. The obturator internus, which is a deep hip rotator that lies deep inside the pelvic wall that Brittney didn't bring with her. So those deep hip rotators support the pelvic floor, and when they're tight, and when we walk, and when we run, and when we exercise, our obturator internus and our piriformis, which support the pelvic bowl, work really hard. Their job is to hold the ball in the socket of the hip. And if you have trochanteric pain, if you have groin pain, if you have deep buttock pain, if you have SI joint pain, and no one's been able to sort it out, please think about those deep hip rotators, because they're probably a problem. At least that's my clinical bias, because I see it all the time in my practice, right? So simply just start stretching your hips and think about your piriformis, right, which is kind of that top stretch on the left as you're looking at it. Cat-cow is fabulous for dynamically lengthening the pelvic floor, not just your spine. Some form of pigeon, figure 4, all of those things stretch the hips, the pelvis, and the pelvic floor. So we need to think about relaxation. We need to start walking. We need to do a bit of stretching. And now we can talk about Kegels. Okay? So Kegels are important because what we know, can you hear me okay? I kind of hate being behind a microphone. Oh, but you're not. Oh, right. So sorry. No. Oh, let me not change that. It's all good. You want to go a little higher. So Kegels are important. So in physiotherapy, we have level 1 evidence behind only a couple of things that we actually do in our whole profession. We do a lot of stuff that we don't have a lot of evidence behind, okay? We have level 1 evidence behind exercise. For persistent pain, we have level 1 evidence behind pain education for persistent pain, and we have level 1 evidence that actually strengthening the pelvic floor helps continence. Okay, level 1 evidence means it's the highest level of evidence, and that's something that we really should be doing. So strengthening is important, but if we start with strengthening and the muscles are like this because of tension, stress, overactivity, not resting, we're not going to become continent, right? Okay. And a lot of people, you know what? They're not all that weak. Once you relax and let the muscles do what they're going to do, they're fine. They don't really need to strengthen, which is why we leave it last, okay? But if you have pelvic organ prolapse, if you have stress incontinence, if you have an overactive bladder, or you just have a desire to age well and live in the blue zones, then you should think about doing some Kegels. What does that look like? We're going to make this really simple because, the only way to know for sure is to do an internal exam, okay? However, everyone close your eyes for a moment if that feels safe. Uncross your legs for a moment if that feels safe. If it really feels safe and we're in a safe space, and we are, you could tuck your hands under your perineum just to feel what's going on down there. Maybe, maybe not, that's okay, whatever you feel like. Your pelvic floor are the muscles between your pubic bone and your tailbone. We've got 3 openings as women. So what I want you to do is I want you to imagine for a moment that there's a ping pong ball sitting right outside your vagina. I want you to squeeze the ping pong ball with your vagina and lift the ping pong ball up towards your uterus. And then I want you to slowly let it go. That's the middle of your pelvic floor. You get a sense of that? Might be easier lying down if it's hard and sitting. It's fine, okay? Now, let's think about the back end. That's pretty easy to feel as well. So a lot of women think a Kegel is stopping a midstream urine. A Kegel is contracting your pelvic floor muscles from pubic bone to tailbone. A lot of women don't realize their rectal muscles are also part of their pelvic floor. That's where the lifters live. So now think about your anus for a moment. That's where you poop from. And then you imagine there's a marble sitting right outside your anus because that's about the right size. And then you draw the marble in and lift it into the rectum. And then you let it go. That's the back end, okay? Oh, now we're gonna go to the front end. So think about your urethra for a moment. Small muscle, small real estate. It's not gonna feel as impressive as your marble and your ping pong ball. Sorry, never does. Everyone always comes back week 2 and goes, you know, those urethral raisins, I'm not sure I'm feeling them. I'm like, that's because they're only like this big versus the rest of the muscles are this big, okay? So imagine where you pee from, that's your urethra. Place a raisin outside your urethra. Squeeze the raisin with your urethra and lift it up towards your bladder. And then you let it go, okay? That is your pelvic floor, ladies. Yes?
Is it natural to have all the balls go at once?
Yes, please. Not only natural, but normal,
Okay.
and the way you want to do it. So here's the problem. Here's the thing. We do a vaginal exam. We talk a lot with our fingers in pelvic health. We do a vaginal exam, and what we're looking for is we're grading strength from 0 to 5, like we do all other muscle strength, right? What we can observe internally is that a lot of women are just squeezing kind of vaginal muscles, and they're not getting the anal rectal muscles. So where the visual imagery comes in is to get women to realize they have urethral, vaginal, and rectal muscles. But yes, what you want to then do is squeeze them all together and lift them inside. That is a full Kegel. And I'm not going to make it more complicated in this group. We do a little bit of fancy things like front to back and side to side and diagonals and crisscross. But you know, don't get too hung up about that, right? But the key is, can you relax your pelvic floor as well as you can contract it, right? It is as important to let go as it is to squeeze and lift. Yes?
My breathing sucks. So how does breathing and the diaphragm play into that? And when should you, is there a better time to breathe in? And
Right. That's a great, yeah. You know, Andrew, that's a really great question, and it really does depend on the individual. If your breath helps you, I'll get you to use it. If it gets in the way, we don't worry about it. So one of the things that we need to do better in medicine and in rehab and in physio is give people less rules. You need to breathe in this way and breathe out this way, and you need to do this. So your pelvic floor is going to get strong whether you breathe, you know, do it on the breath out or you do it on the breath in. I sometimes play with that in the clinic, but honestly, I don't want to boggle people's minds at this point too much because it's not that important. So great question. Thank you for that. Okay. The prescription, what we have good evidence around is 3 sets of 10 of each of those, or all together, thank you, 30, once a day. Not 100, not a 5 reps every time you're at a stop sign, because as Ashley knows, if we're going to get strong muscles, there's no time you go to the gym and do 10 reps and come back 3 hours later and do 10 more. And then 6 hours later, you do another 10. That's not how muscles get strong. They get strong by doing 30 in a row with a bit of a rest in between. Okay, so once a day, 30 repetitions. When you're continent and you've got good control, the way I get my patients to keep doing them, because they are boring. Make no mistake, there is nothing exciting about doing 30 Kegels, so we don't stick with that forever. Easy way, 2 Kegels post-void. You pee, you wipe. As you stand up, you do a Kegel and zip your pants together. Walk to the sink. When you wash your hands, do another Kegel. Once you're strong, if you did that every day for the rest of your life, I can guarantee that you will not be incontinent. Pretty much. I can't guarantee anything, but you will not be incontinent because you will have stayed connected to those muscles and they will maintain their strength even though you're not doing 30 in a row at that point anymore. Okay, they're little muscles. They don't need all that load. They just need strength and coordination. Yes, question at the back.
So I was at a urologist with my father-in-law, and
Yeah.
they were advertising these crazy chairs. It was like 10,000 Kegels,
Right.
25
Right.
minutes. And I'm like, oh, that looks gimmicky.
Mm.
And it started coming across my social media.
Mm-hmm.
So I'm guessing it is like full gimmick.
Mm-hmm. Yeah. So it's high intensity neuromuscular electrical stimulation. Unfortunately, there is money to be made with an EMSLA chair. So the other thing I'd like to always say at this point is that many people don't have physiotherapy coverage. And that is a real, so we're addressing that actually. Yay, we'll talk about that in just a moment. So that's one problem. But I do say to people, listen, the average person with incontinence spends $1,000 a year on incontinence products. It costs $500 to see a physio 5 or 6 times and fix the problem for life. So that's $500. The EMSLA chair is $3,000 for 4 or 5 sessions. And it's no better than actually, so maybe, I treat continence all day. Brittney, I do 2 days a week, Brittney does 4 days a week. Between the two of us, we might use electrical stim with somebody's pelvic floor that really can't find it, really can't get strong, 3 times a year, right? So very few people actually need electrical stim. It's a very passive way, and it is not telling the whole continence story, and it is making it socially acceptable. You don't take your pants off, you sit on this chair. The evidence behind it is weak. There's no good, strong, randomized controlled trials that support it. So that's about all I have to say about that. But yes.
I'll speak to that for a second. Our colleague at MAC just did a scoping review on it, and it essentially came out that the Insella is no better than any other modality for pelvic floor, but will cost about 6 times as much. And then the other thing with the Insella, and again, and we're a bit biased as physios, but it's not an active care strategy. So once you've gotten better with it, you need to keep going every so often to get like a bit of a top up from strengthening. Whereas again with physio, we really want to discharge you. Like I always say, I love seeing you. I never want to see you again. And so it's teaching you that kind of active strategy. So there's nothing wrong with it. I have patients who use it, and if you have the financial means and want to try that route, but the evidence does not say that it's any better than doing anything else. And that's just a recent 2024 scoping review.
And was there another comment then as well? Yeah.
In regards to prolapse,
Yeah.
like this, support prolapse, and how does that, I don't know if you plan to talk more about prolapse?
We're not going to talk because, again, it was, not enough time to really dig in. So pelvic organ prolapse is where your organs are pushing your vagina down and out, or your uterus can actually track down the vaginal canal. So it's your organs starting to push your vagina like a tube sock inside out. There's lots that can be done conservatively. Again, strength training, early identification, grade 1, grade 2. Lindsay, you might have a comment on this. Show me a vaginal delivery. I'll show you a grade 1 and 2 prolapse of a rectum, rectocele or cystocele. They're common in and of themselves. They're not a problem. If we have one, keeping our pelvic floor strong. So I have a grade 2 cystocele. I've had one for 36 years. I lift heavy. No, it's her older brother's fault. It's true. And so there's lots that can be done about prolapse. By the time we get to a grade 3, we need to think about pessary support, plus pelvic floor strength, maybe surgery. So those are sort of the comments around that piece. But again, don't assume with a prolapse you are necessarily weak. You also might be tight and weak. And so we have to kind of think about relaxation, activation, mobility, and then do your strength training. Okay, yeah.
I just wanted to make a comment about physiologic treatments like the chair.
EMSLA chair, yeah.
EMSLA chair, as compared to seeing a physiotherapist, as well as that you miss out on the holistic treatment part of physiotherapy care, which especially, I get like wicked emotional about the kind of treatment that I've had in the Vandyken's practice, and I'm just you can't. I don't believe that you can really treat a physiologic problem without a addressing all of the components that, you know, contribute to the development of that problem.
Yeah.
So.
Yeah, you're absolutely right. And we talk about prolapse again for a moment. One of the big reasons why prolapse becomes symptomatic is people are constipated. And constipation, the treatment of constipation is not Metamucil. Sorry, Lindsay. I hope you agree. But a lot of that's just take Metamucil. If you're not pooping every day easily without strain or mess or fuss, you need to a squatty potty. There's lots of things that can be done, and we're running out of time, but we will get there, I promise. How are we doing? Can we go 5 more minutes? Everyone okay? Okay. All right. Okay. And then the other message I want to say with strength training is it's not just the pelvic floor, right? We need whole body strength training. So I love the fact that, you know, Ashley was here and we're being given permission as women to lift heavy, but I also don't want to put pressure on you to lift heavy. I hate weight training. I've always hated weight training. It drives my daughter crazy. So, the most evidence-based, yes?
I will say
Yeah.
that I always say that heavy is relative.
Right.
And also, it doesn't have to be big, heavy weights.
Right.
It just has to feel a little bit.
So whole body resistance training. So the 7-minute, if you Google on YouTube, the 7-minute HIIT challenge, right? This is, sorry? American College of Sports Medicine created this series of exercise. It's the most evidence-based, time-efficient, whole body strength training program. Ladies, this is all I do. This is all I will ever do, even though my daughter rolls her eyes. Yes, Ali.
We're running out of time, but speaking of social media, my social media is full right now of gluteal tendinopathy.
Yes, me too.
That keeps it out of my ass.
Yes.
Same. Gluteal tendinopathy.
Gluteal? Yeah, go ahead.
What's working for me is relaxation.
Mm-hmm.
That's the old, like I can't do pigeon, I can lunge right now, which is a bit weird. But it's so goddamn painful.
So gluteal, again, here's the downside of modern medicine, and it is a downside of modern medicine. We now have MRIs and imaging that we can see all kinds of things, and we know this in hard sort of spinal changes, we know this in soft tissue changes. Unfortunately, when people have deep glute pain, it is, and now we do an MRI, we see tendinopathy, we say, well, there's your pain. Chances are it's not. I see so many of my patients with gluteal tendinopathy who actually have OI and piriformis tension. And Ali, I know, you've stretched your, so that's not the thing with you. And everyone's going to be different, right? So don't get hung up on your imaging either, right? Your imaging is not your pain.
So it wasn't imaging, I was just wondering if it was
Okay.
real because it was social media.
No, yeah, right, yeah. Yeah, so, how much protein should we have? Like all of those things are coming through on social media, and you have to really start to question it, right? So anyways, 7-minute challenge can be as simple as that, okay? Don't have to make it more difficult. Little things add up for big pelvic floor health. Don't pee just in case. Yes. Your bladder is meant to fill up, and your bladder is meant to only empty when you have to pee. Stop peeing when you leave the house.
Don't make your kids do it.
And don't make your kids do it.
I learned from you.
Yes.
Don't ask the kids to pee just because you're leaving.
That's right.
Why do we always have to pee 5 minutes after you leave?
Well, so when you leave, ask yourself, when's the last time I peed? So just ask yourself. If I peed an hour ago, you should not have to pee. If I peed 2.5 hours ago, even though I don't have to pee, maybe I could pee. So I know I don't have to stop in 10 minutes,
And
right?
if you're a nurse and haven't peed in 12 hours,
That's all. You probably haven't drank enough water, and you've probably been too busy, right? I'm not going to talk about staying hydrated because, again, Allison did a great job with that. Relax on the toilet seat, ladies. You will not catch anything from the toilet seat. If the toilet seat looks dirty, put toilet paper on it. Hover once in a while if you absolutely must, but the only way to empty your bladder is to sit. Relax your pelvic floor, relax your hips, and let your bladder empty. Use a footstool for bowel movements. We are meant to squat to poop and pee. We were not meant to sit on our lovely emperor's thrones called our toilets. They're lovely. That is not how we were designed to pee or poop. Poop especially, we need to put our feet up so that the angle between our rectum and our anus goes from a 90-degree angle down to straight out the poop chute. Last thing It is okay to delay the urge to pee. In fact, it's good for your bladder to hold for a little bit. That is actually good training, not 12 hours. However, the call to stool, hello, have to go poop, go. Because if you don't, the poop goes back up into your lower intestine, it dries out some more, and you become constipated. So you don't have to be urgent about your bathroom, like, oh, I need to go in this moment, but in the next 10 minutes, go find a bathroom and empty your bowel, okay? Yeah. Pain with sex, again, we want to just cover this a little bit. Our vulvas are self-cleaning ovens. Our vaginas are self-cleaning ovens. We have good, healthy bacteria. Please don't use soap on your vulva and vagina. Just use water, okay? Don't use Vagisil. Don't douche. Don't clean those good bacteria. Give it a try. See what you think. Vaginal estrogen, we've been talking about that in this program. Excellent for moisture, painful sex, okay? Bladder infections, if you have chronic UTIs, talk to your primary care provider. Vaginal moisturizers like Gynotroph, Repagyne, Good Clean Love, vitamin E, coconut oil, all of those things are good, healthy moisturizers. Think about your vulvar skin like your face. You put something different on your face than the rest of your body. Same with your vulva. These are good moisturizers, okay? Use a good lubricant for sex. That is not KY jelly. Anything with parabens or propylene glycol is a lubricant in the moment and then dries you out. So there's better lubricants out there. And then sex is about relationship. Relationship with yourself, relationship with your partner or whomever it is that you're having sex with. And first of all, Come As You Are is a great book for women's sexuality and understanding our sexuality. And then Come Together is also written by Emily Nagoski. And it's a fantastic book about long-term monogamous relationships and how to really kind of bring yourself into that intimacy space. Okay?
Sorry, Carolyn, can you just briefly say the difference between a vaginal moisturizer and a lubricant?
Yes.
And what they're used?
Yes, so moisturizer is for daily moisture use. A lubricant is for love.
That's
LL. That's how I remember it. Yeah. Thank you, Alison. All right. Very exciting. The Algonquin Family Health Team actually had some funding and have asked Britt and I to create 4 modules of self-care. So the first module will be pelvic health, and it should be ready by July 1st. I'm saying that publicly, so maybe that's going to put some pressure on us. It's going to be an online module that you will get access through your primary care provider, and it will be a self-directed module to help you regain your own pelvic health. Okay, not everyone has access to care, and we're hoping that that's going to start to level the playing field. And then we'll do back pain, and then we'll do knee pain, and then we'll do shoulder pain.
Free.
They'll be free. Yeah. Okay. All right. How can I not feel overwhelmed? Right? Keep it simple. None of us are perfect. We don't have to do it all to live to 100. We have to do 80 to 90% of eating good food, sleeping well, having a relaxation practice, exercise, right? Those are sort of the basic things. And so don't get overwhelmed. I really want you to think about menopause as the chance to pause and reevaluate the direction you're going, and just think about what are the things that I could do better to live better, to have a better quality of life. And that's it. Thank you very much. Any questions yet before? And we have gone a bit over time, so I apologize. Yes, go ahead. Yes.
You just get a referral from your physician, and
How soon can we ask? So July 1st. July 1st. You will get a code from your clinician. So anytime someone has a pelvic health complaint, they will be offered to do a self-care program, a self-directed self-care program, or they could have a referral for physio. But again, you know, when we look at sort of the demographics across Muskoka, I believe that 80% of people who live in Muskoka have a combined family income of less than 75,000 or less. And so we do not have equal access across the board, and so that's what we're trying to create better access to. Okay. Yeah.
And is that with any family physicians
Yeah.
across Muskoka or just?
Correct. Correct.
Nurse practitioners.
Nurse practitioners
And
midwives.
Once we open up the annex, there will, like,
Right.
whoever the doctor there is tied to the Algonquin Family Health Team and to that, so they will have access to it as well, from what we said. Yeah, so people will
Yeah.
have access.
Okay. Yes.
Is there, as someone who's had a hysterectomy, not a complete one, there was absolutely no discussion about how that might impact my body.
Right. Right.
And so, I don't know what's
Right.
going on in there. I mean,
Yeah.
I literally had to ask, where do my ovaries go? Like, could I go to and like pop one up? Like, are they just floating around in there?
Right.
So, like,
That's a
is
great
there
question.
any
How do
kind
they
of
take it without taking the
impact
cervix?
on your pelvic floor health that you would tell somebody who's had a hysterectomy?
There is, because you're actually missing a keystone organ at that point. So your uterus is a keystone organ for support of the other organs. So you are, and I can't quote statistically, but you will be potentially at a higher risk for pelvic organ prolapse. That's probably your biggest risk factor, I would say, at this point. Your ovaries are within your peritoneal cavity. I promise they aren't going anywhere. They're not falling out your vagina, and you're not going to cough them up in the other direction. So that's good, but you potentially have a higher risk for a pelvic organ prolapse. So again, knowing what to do about that and how to keep your pelvic floor muscles strong and manage your pressure, it's pretty simple.
Would have been nice to know that.
Yeah, yeah, okay, great question. Anything else? Yeah.
If you have someone who has chronic SI joint pain, piriformis, hip flexor, kind of all at the same time,
Yeah.
they're active, they strength train, they stretch, they see regular physio, chiro, and nothing really touches it. Could that be a time where you would see a problem?
156%. Yes. So we see a lot of, like, this is a pretty active community, and I cannot tell you in the running community, in the athletic community, how much OI and piriformis sort of sensitivity and tension that we see, because you can only get at those muscles internally. I don't care how many people tell you they're going to dig into piriformis with their elbow through the butt. You cannot access piriformis except for internally. And if you have global sort of tension in that area, I would also be looking at relaxation, but also remapping strategies. So tension, like pain, is a protective response. And once it's learned and maintained, your brain probably has a hard time getting out of that protective mode. So it needs to be taught to do that. Yeah. Okay. Yeah.
I would just like to add my personal experience working with Carolyn. I went to see her because of low back pain, thinking I work with children, it's from carrying them improperly for all these years. And what we determined was that it was my scar tissue from my C-section was pulling like my pelvic floor, my hips, everything out of whack. So we did a lot of massage and release on that, which was, it hurt. Like, it didn't feel great, but like this is also something like you're saying with his, like I wasn't told recovering from a C-section, like massage your scar every day, or, and so that was what we figured was the issue. But I just went because my back hurt, and then
Lo and behold.
Carolyn was all up in my business. All right, well, let's do it.
Yes. And look, we still smile and talk to each other. It's all good.
But I mean,
Yeah.
you know, recovering from a C-section is a very big life event when you have organs taken and placed on the table while they take out a baby and put back in, and then you hope it's all in the right place. So just that's another reason why I went. So something to think about too.
Thank you. Pain is always a whole person event, right? We have to stop sort of thinking about pain as a structural piece. In persistent pain, it rarely is. And that's what we know very clearly at this point from the research. But it is very hard culturally and from our society's perspective to stop looking at MRIs and stop looking at x-rays and stop looking at structure because we've been trained so hard to do that. But we again, I've been practicing for almost 40 years. Over my career span, the rate of disability from MSK pain has increased by 62%. So even though we now have MRIs and imaging and all the fancy stuff that we have, we suck at treating MSK pain and not, sort of allowing that disability to happen. So we have to change how we do things, right?
If you had somebody who was not comfortable with an internal exam,
Right.
do you still have ways to treat them?
Yeah, so we always give people the option. So first of all, there's lots of things that we can do. We'll have to make a few assumptions, and we'll do a lot of remapping strategies and stuff, but internal exam is not mandatory. It's helpful, but it's not mandatory, for sure, yeah.
I'm just wondering, can we self-refer, or do we have to get?
Physiotherapy is a direct referral profession, so you can just call our office and, yeah, you don't need it, unless you need it for your benefits, in which case your physician just has to write a script, yeah. Any other questions? Awesome. You guys were a great audience. Thank you for your laughter and your participation.
Thank you, Brittney and Carolyn, ladies. That was amazing. Oh my gosh, always learn so much. Anyways, post quiz. Everybody, show of hands. Who's done? I'm gonna single you out. No, I'm just kidding. There. Yes. Awesome. Thank you, ladies. We'll see you guys next month. I can't remember what it is, but we'll see you then. Turn this bad boy off. Oh, this one doesn't have an off button.